Bismillahirrahmanirrahim. With you, Dr. Raghda Ghonimy. I'm Professor of Cardiology, Tanta University. Today, we will review with each other the left to right shunt. Our objectives to know the meaning of shunt, the different type of shunt, some cases scenario we will discuss with each other, to know also the pathophysiology of left to right shunt and the management strategy of the intra-cardiac shunt. What is the meaning of shunt? Shunt means abnormal pathway inside the cardiac chamber or in some blood vessels. This is abnormal path allow the blood to diverted from cardiac chamber to another cardiac chamber, from one vessel to another, or from the vessel to the cardiac chamber. And here we can appreciate the vascular shunt is synonymous with the fistula. What is about the type of shunt? It can be intracardiac shunt, as in cases of atrial or ventricular septal defects, or extracardiac shunt, which have a different types, either systemic to systemic. For example, persistent left superior vena cava drain in the left side of the heart, or systemic to pulmonary. For example, patent ductus arteriosus, where the duct drain from the pulmonary artery to from the aorta to the pulmonary artery, or pulmonary to pulmonary shunt, as in cases of pulmonary arteriovenous malformation, or the last type is the pulmonary to systemic, as in cases of partial or total anomaly pulmonary venous drainage drain in the right side of the heart. The last type is the created shunt, which can create it either surgically in cases of small or non-sufficient pulmonary circulation, in cases of tetralogy of Fallot or hypoplastic pulmonary arteries, where the surgeon create PT, which is called modified Palalock-Towsing shunt, to allow more blood to come from the aorta to the pulmonary artery, helping the pulmonary to grow until the final surgery well done. Or transcatheter shunt, as in cases of transposition of great arteries, where the pulmonary and circulation parallel to each other, not in series. So we need mixing of the blood through the interatrium. So we use the Apollon to induce atrial septostomy and good mixing of the blood at the level of the atrium. Speaking about the left to right shunt, we have different types. Either cardiac, as atrial septal defect, ventricular septal defect, or atrioventricular septal defect and patent ductus arteriosus, or a vascular shunt, as total and partial anomaly pulmonary venous drainage. To be more interesting, we will discuss with each other the different type of shunt in a form of cases scenario. Our first case is medical student, 20 years, male, complaining from occasional palpitation. He runs in the track every other day without complaint. His resting heart rate was 85 beats per minute, blood pressure 110/70. By auscultation, we found accentuated first heart sound with fixed splitting second heart sound. So we take the decision to do ECG and X-ray for this medical student. The X-ray, we can appreciate cardiomegaly of right ventricular apex. To the right side of the sternum, we can appreciate right atrial dilatation. There is significant congestion of the pulmonary circulation in the central and peripheral pulmonaries. Revise the ECG, we can appreciating atrial dilatation from the P wave in the limb lead, and revise the chest lead. We can appreciate right atrial dilatation and right ventricular dilatation and right ventricular stream pattern. What is the first possibility or what's the first suspicious for this X-ray and ECG? Actually, we discuss a case of atrial septal defect. So speaking about the atrial septal defect, what is the main factor determine the left to right shunt across the atrial septal defect? Is it the difference in pressure? Actually, no. The both atrial pressure is low. So here the pressure is not the main factor. Is it vascular resistance? No, because the vascular resistance controlling the shunt at the level of the great vessel. So what is the main determination for the left to right shunt at the level of the atrium? It will be the ventricular compliance. Here we speak about the right and the left ventricular compliance, which is the main factor affecting the direction of the shunt at the level of atrial septal defect. Second question, which chamber of the heart will be firstly affected? It is the right atrium or the right ventricle, or which chamber? Actually, the recipient chamber will be affected first, which will be the right atrium. So we can observe in the right atrium, in the cases of atrial septal defect, the right side of the heart will be dilated, and this is the first interpretation when we doing echo and found right side dilatation. We must exclude the presence of atrial septal defect. Why this medical student complaining from palpitation? Because actually we have a right atrial dilatation which will stretch the atrial wall, and the first and the most common symptom in cases of atrial septal defect is the arrhythmia, which is the main cause of palpitation here. Revise the echo. The upper panel, we can appreciate the interatrial septum in the middle and the atrial septal defect where the blue coloration path from the left atrium to the upper part, the right atrium. The lower panel, right side, the right part is right side dilatation, which is the landmark for the atrial septal defect, and in the left panel we can appreciate the flattening and the deviation of the interventricular septum to the left, which mean we have a right ventricular volume overload. And this is the different type of atrial septal defect. Near the superior vena cava, we found this superior venosus defect. Near the inferior vena cava, we found the inferior venosus defect. At the middle of interatrial septum, we can appreciate the secundum atrial septal defect, which form about 90% of the all atrial septal defect, and which is the most suitable type for transcatheter closure because I have a sufficient rim around this defect. From the superior, inferior, from posterior, from the anterior axis, we found sufficient rim in most of the secundum atrial septal defect. The fourth type is the coronary sinus, which is mostly associated with persistent left superior vena cava, and sometimes the roof of the coronary sinus is absent, which is called unroofed coronary sinus. And the last one is the primum defect, which found in the Down syndrome at the inlet of the ventricle near the mitral and the tricuspid valve, and most of the case associated with cleft mitral valve and some degree of mitral incompetence. This is the figure. With this figure, we can revise the pathophysiology of left to right shunt across the interatrial septum, and here we can appreciate the right atrial dilatation and right ventricular dilatation. If we have a small atrial septal defect, most of the cases pass asymptomatic and 20% carry possibility of spontaneous total closure. Larger defects come with the symptom of right side volume overload and congestion, but this is not common as the palpitation. The palpitation is the commonest symptom in the atrial septal defect. Some cases, the first presentation come with a stroke, and this case, the first possibility to have a patent foramen ovale with a paradoxical embolization through the atrial septal defect. What is the management strategy? It will be a separate section in our review today, but for small hint, in asymptomatic patient, we have no management. We leave them for follow-up. If the patient have a specific symptom of congestion and pulmonary overflow, we will start about anti-failure measurement, medical anti-failure measurement, and after that, when the patient fulfill the criteria for transcatheter or surgery, we can go for intervention. This is the last guideline of American Heart Association and American College of Cardiology for the recommendation of intervention in secondum atrial septal defect 2018. And if we revise with that with each other, we speak about the left panel where the left to right shunt is our scope today. Hemodynamic significant shunt mean I have a pulmonary flow increased more than third the systemic flow, or I have pulmonary vascular resistance started to increase but still less than 50% of the systemic. If this is the situation and the patient hemodynamically significant disturbance, so here the intervention either catheter or surgery become class 1. But if the hemodynamic is stable, here we are doing the intervention in an elective manner, so it carry the recommendation to be. If the patient have pulmonary vascular resistance become more than 50% of the systemic, or the flow increase to become more than 2/3 of the systemic flow, here the intervention either surgical or catheter is there, but after revised with the adult congenital heart disease and pulmonary hypertension team, and the recommendation here is to be. This is example for transesophageal echo-guided atrial septal defect closure. We can appreciate the left disc in the left atrium and right disc in the right atrium, and there is no significant residual flow across the device. And here the device, after we put the device in actually position, we do some sort of Minnesota pushing and pulling the device to test its stability. And when we are happy with the device position and everything is okay, we can safely release the device. Second case is a female child, 7 years old, to a 23 kilogram, full term, complaining from dyspnea palpitation with effort. On auscultation, we found pan-systolic murmur grade 4 over 5, grade 4 to 5 over 6. There is no diastolic murmur, and we found first heart sound muffled, no systemic congestion, or the congestion is pulmonary manifestation, heart rate 90 beats per minute, and saturation was 99. Revising the X-ray, we found also cardiomegaly of left ventricular apex, and we can appreciate also the pulmonary congestion. So to correlate the X-ray with the symptom of the patient, we mostly speaking about a case of ventricular septal defect. In this slide, we can revise the different type of ventricular septal defect. From the top to the bottom, we will find the first one is subpulmonic VSD, just below the pulmonary valve and carry the left coloration in the other slide, followed by the perimembranous VSD or subtricuspid VSD, which is followed the yellow coloration in the low figure, and just below the edge is a subaortic VSD. Follow the green coloration in the lower slide. This is followed by the inlet VSD, which is found in the partial and the complete AV canal, and followed by mid-muscular VSD and the anterior or apical multiple VSDs. Correlated the previous slide with the echo. The upper left panel, we found the mid-muscular VSD. The upper right is the perimembranous VSD. The lower left is the subpulmonic VSD, and the lower right is the subaortic VSD. The subpulmonic and subaortic can be found in the same person if the disease defect is a little bit large, and which is called a doubly committed or subarterial VSD. Come to the questions. What is the main factor determine the left to right shunt in cases of VSD? Actually, it is the pressure difference between the left and right ventricle, as we all know that the left ventricular pressure is 4 times more than the right ventricular pressure. Second question, the shunt in the VSD is systolic or diastolic or both? Actually, here the shunt is only systolic. Why? Because the diastolic pressure in both left and right ventricle nearly equals 0. So no difference in the diastolic pressure. So in VSD, it's carry only the systolic pressure and systolic shunt. Which chamber of the heart will be firstly dilated? Is it the right ventricle or right atrium or the left atrium? Actually, the chamber affected first is the left atrium, because the shunted blood found the right ventricle in a systole. So all the blood will go through the pulmonary artery to return back to the left atrium through the pulmonary vein. So the first chamber will be affected is the left atrium. We can appreciate in all cases of sufficient VSD, left atrium and left ventricular dilatation. What is the commonest complication in cases of VSD? Small thinking. We have a very high velocity jet through the VSD. So here the most common complication is the infective endocarditis. And this is the shorthands about the VSD. VSD is the commonest congenital heart disease. It occurs when the ventricular septum have incomplete closure or incomplete development. The defect size determines the degree of shunt and the clinical presentation of the patient. Asymptomatic patient have a small shunt, and we can follow the shunt till spontaneous closure with the time, but larger defects increase the pulmonary flow and pulmonary vascular resistance and do injury in the pulmonary flow, and it's up to increase pulmonary vascular resistance to the degree that can reverse the shunt, which has become right to left, which is also called the Eisenmenger syndrome. Larger defect need medical management for controlling the symptom till the patient is suitable for intervention, either surgical or catheter, as in cases of intraseptal defect. Here the management strategy a little bit similar to the atrial septal defect strategy, with the same guideline of American Heart Association, American Colleague of Cardiology in 2018. The only difference is the presence of infective endocarditis in the guideline, which tell us we must intervene with these cases if the infective endocarditis are there. And this is example for ventricular septal defect, perimembranous one. We can appreciate from left ventricular angiogram, the shunt come just below the aortic valve and go to the right ventricle. And here we put the device from the left side to the right side. We release the device. And after release the device, we do other ventricular angiogram to be sure that there is no residual flow across the device. And when we are happy with the results and there is no complication with the echo man guided our procedure, we can safely release the device. The last case scenario today is this case: young female, child, 3 years, underweight. It's about 20 kilogram, complaining from easy fatigability, dyspnea, and recurrent chest infection. With auscultation, we found accentuated second heart sound, but with continuous murmur at the base of the heart. Revised the X-ray, we can appreciate the left ventricular apex and the cardiomegaly, but here we can appreciate also the huge size of the pulmonary knuckle with significant pulmonary congestion in the central and the peripheral pulmonary circulation. The possibility here also, after correlating the X-ray with the clinical of the patient, yes, it's a case of patent ductus arteriosus. The ductus arteriosus closed shortly after birth by about 72 hours. Failure of closure, mostly in the preterm baby, which if the mother have a Rupella syndrome. In the fetal life, the shunt through the PDA was right to left. After newborn, the shunt returned to be left to right, which is normally, and the PDA carry a continuous murmur. If it's small, mostly it comes asymptomatic and can close spontaneously through the first 3 months. After that, it will never close. Larger PDA have most symptoms as heart failure early, infective endocarditis, and coronary steal, which do some ECG changes when we revise the ECG of the patient with PDA. Neglected PDAs, the patient can come to us in the adult ages with cyanosis because of a reversal shunt, and here we can appreciate the differential cyanosis with the cases of PTE, pulmonary hypertension. The closure can be done either medical in the preterm baby using endomethacin, or after that, if the patient in heart failure, we can send them as early as possible for surgical closure. But if the baby can tolerate to 4 to 6 months, we can go for transcatheter closure. So our questions: what is the main factor determined left to right shunt through the PDA? Yes, it's also the difference in pressure between the pulmonary artery and the aorta. Second question, if the shunt systolic or diastolic or both? Yes, in PDA we have both systolic and diastolic shunt. Why? Because in the carotid arteries we have difference in both systolic and diastolic pressure. The aortic pressure greater than the pulmonary pressure in both systole and diastole by about 4 times. So we can appreciate in cases of PDA a continuous flow in systole and in diastole. The third question, which chamber will be firstly affected? Small time of thinking, we can observe systolic and diastolic flow from the aorta to the pulmonary artery during the whole circulation. Yes, actually the pulmonary artery will be the affected vessel firstly. We can appreciate in all cases of PDA dilated main pulmonary artery and its confluent branches from increased flow, followed by increase in the left atrial and the left ventricular size. The most common complication, as in cases of VSD, yes, it's infective endocarditis from high velocity jet and the trauma that happened from the continuous flow through the PDA. By the echo from the upper left channel, we can observe the color flow come from the descending aorta to the main pulmonary artery up to the pulmonary valve. The right upper channel, we can appreciate the continuous flow all over the PDA, and the lower figure this is the ductal view, which can figure out all the duct. We can calculate the aortic ampulla, the pulmonary end, the shape and the size and the morphology of the duct to decide which method of closure is suitable for this patient. Revise the same guideline of American Heart Association, American College of Cardiology 2018. We found nearly the same indication of PDA closure like the VSD closure, comparing the aortic flow to the systemic flow and the aortic and the systemic resistance with the pulmonary resistance. We come to the same indication. And this is case of very wide PDA. We can appreciate from the aortogram the duct that fill the pulmonary artery, and then we put the device. Here is the muscular device to put disc in the pulmonary and disc in the aorta, and when we're happy with the situation and the site of the device, we can release the device. After that, we take other control angiogram to be sure that there is no residual flow and everything is okay, the aortic flow is okay, so we can release the device. To wrap up the previous slides, when we want to diagnose the intracardiac shunt, we depend on the clinical presentation of the patient, the ECG, the X-ray, and our gold standard actually is the echocardiogram, either transthoracic or transesophageal or both of them. Sometimes we need to do CT angiogram for the cases as in adult PDAs, just to figure out the morphology of the duct, which can be tortuous, and we can find a lot of calcification in adult PDAs. MRI, sometimes we need it is to check the ventricular morphology, especially in cases with tetralogy of Fallot after surgery or something like that. And speaking about the cardiac catheterization, it is the cornerstone in the management of left to right shunt, and we sometimes need to do diagnostic cardiac catheterization before intervention in cases of intracardiac shunt with elevated pulmonary artery pressure and pulmonary vascular resistance, to put a clue indication if these cases is suitable for intervention or the time of intervention come out. Stepwise approach for echo in the diagnosis of intracardiac shunt start step by step from the subcostal view, from assessment of cardiac situs, then to determine which type of shunt we have, what is the effect of this shunt on the hemodynamics of the heart, which chamber is dilated, what about the pulmonary flow, what about the aortic flow, and if there is other congenital anomaly present with this intracardiac shunt. So we put the final decision if this shunt is suitable for transcatheter or for surgical or for follow-up and so on. Also this figure can put to us a summarization for the pathophysiology of intracardiac shunt. We discuss it in the atrial septal defect and in the ventricular septal defect. What about the patent ductus arteriosus? We just put a hands, because here the shunt come during systole and during diastole as well, so we can appreciate some degree of coronary artery steal, the coronary circulation filled during the diastole. So the diastolic aortic to the pulmonary shunt do some sort of coronary steal, so the patient with PDA can come complaining from chest pain. Also, to conclude the pathophysiology of left to right shunt, it depends on the size of defect, the pressure gradient between the cardiac chamber or arteries, pulmonary and systemic vascular resistance, and the difference between of them controlling the direction and the degree of left to right shunt, relative compliance of right and left ventricle, especially in cases of atrial septal defect, and also the blood viscosity. The size of shunt can be measured either directly, and we can classify the small if it's less than 5 milli, or moderate from 5 to 8, or large when it's more than 8, or more accurate method when comparing the size of the defect with the aortic annulus. If it's 1/3, so it's small shunt. From 1/3 to 2/3, it's a moderate, and if more than 2/3 of the aortic annulus, we're speaking about large shunts. The shunt flow can calculate in both echo lab and in the cath lab. In the echo, we have a principle that told us about the volume of the blood moving in a certain tube, can calculate it by multiplying the cross-sectional area of that tube with the velocity of fluid moving inside this tube. So we can get the pulmonary flow and we can get the systemic flow, and you divide both of them over each other. For example, revise the upper left panel. Yellow color is the diameter of left ventricular outflow tract. The upper right is the velocity time integral over the aorta. So we can, from both of them, we can get the systemic flow. The lower left panel, the red coloration, is the right ventricular outflow tract, and the lower right is the velocity time integral over the pulmonary artery. From both of them, we can calculate the pulmonary flow, so we can get both pulmonary flow and systemic flow and again the ratio between both of them. In the cath lab, it's a little bit different, so it depends on a specific indicator according to the Fick principle, which follow the indicator to calculate the cardiac output. Here, we first depend on the oxygen consumption that have a certain table correlating the consumption with the age and sex, followed by carry oxygen sample from different cardiac chambers. We take sample from each cardiac chamber. Then, calculating the pulmonary flow depend on oxygen consumption over the difference in oxygen between the start and the end of the pulmonary circulation, which is the pulmonary vein, minus the pulmonary artery, and the pulmonary venous saturation actually is higher than the pulmonary artery. By the same conception, we can get the systemic circulation as the systemic flow by dividing the oxygen consumption of the same patient, dividing on the difference in the systemic circulation oxygen content, which is the aorta minus the mixed venous oxygen saturation. Here we can ask me what is the mixed venous oxygen saturation. It is five samples of oxygen come from superior and inferior vena cava, and the 3 samples come from the right atrium, high, mid, and low right atrium. The summation of these 5 samples can be divided over 5 to get the mixed venous oxygen saturation. So, in left to right shunt in the cath lab, we can appreciate oxygen step up at the side of shunt. We can find oxygen step up in the right atrium, so it is the atrial septal defect. If the step up of oxygen found in the right ventricle, so it is the VSD, because the shunt here at the level of the ventricle, and so on. In the right to left shunt, the oxygen here will be oxygen desaturation in the left side. What's the meaning of desaturation? It's mean the deoxygenated blood of the right circulation mixed with the oxygenated blood in the left side, causing this desaturation. So, after recalculating the systemic flow and the pulmonary flow and taking our samples and appreciating the step up in the right side in cases of left to right shunt or desaturation, we come to the last stage, which is the calculation of the vascular resistance. And here we can revise the Ohm's law, which tell us the vascular resistance equal to pressure over flow. We have already the flow, and we can get the pressure directly in the cath lab from each cardiac chamber. We measure the systolic, the diastolic, and the mean pressure from each cardiac chamber. And this is the conclusion of the shunt. We can correlate it with the direction of the shunt with the shunt flow. If the shunt flow, which is mean QP over QS equal 1, this is the normal, because normally the pulmonary flow equals the systemic flow, and this is mean I have no shunt. If this ratio become more than 1 but less than 1.5, so I have small left to right shunt. Increasing this ratio from 1.5 to 2, this means I have a moderate left to right shunt. More than 2 mean I have large left to right shunt. What happened if we found that this shunt is reversed and become less than 1? This means the direction of shunt also is reversed, and here the shunt become from the right to the left. And also in the cath lab, this is a conclusion of the pulmonary vascular resistance. If we found this resistance less than 2.3, this means this patient is very good and suitable for closure of this shunt. But increasing the vascular resistance to be more than 4.6, and in some literature if more than 5, this means this patient become contraindication for intervention, and intervention carry a hazards for this patient up to cardiac death. And some patient we found this ratio between 2.3 to 4.6, and this is what's called to us the gray zone in the cath lab. It's not less to 2.3 or more than 4.6. This category of patient, we do what's called a reversibility test, either by nitrous oxide or by inhalation of oxygen 100% for about half an hour, or we do what's called occlusion test. Occlusion test either by balloon or by the device, and leave the patient for about half an hour, and then revise all the hemodynamic to test the reversibility of pulmonary vascular resistance. If so, and it's become less than 4.6, we can go for intervention and closure the shunt. The management strategy also can be summarized in these points. Just for follow-up in small asymptomatic shunts, medical management in some moderate shunt and still not fit for intervention, either catheter or surgery. Transcatheter device come now side by side with surgical closure if it's fulfilled the criteria for catheter intervention or surgical closure in these shunts. To sum up, left to right shunt characterized by back leak of the blood from systemic to pulmonary circulation. Blood volume and pressure in the pulmonary circulation become abnormally high because of this shunt. If the shunt is significant, there is a progressive damage in pulmonary vasculature and the gradual development of irreversible pulmonary hypertension. To sum up this literature about left to right shunt, in small VSDs and PDAs, the direction and amplitude of shunt depend on the pressure difference across the shunt. Larger VSDs and PDAs, the shunt direction and magnitude depend on the vascular resistance. Speaking about the ASDs, the magnitude of shunt depend largely in the relative ventricular compliance and the difference between right ventricular and left ventricular elasticity. Defect size determined by comparing the diameter of the defect with the aortic annulus of the same person. Cardiac shunts are associated with a lot of complications as heart failure, pulmonary hypertension, infection, and arrhythmias. Closure of these shunts may prevent the reverse of these complications. Surgical closure is safe and validated. Percutaneous closure by device have a comparable safety and efficacy in a specific situation and may be associated with less morbidity and less invasive procedure. And thank you very much.